Vaccination in Manitoba. And it's going to be hosted by the University of Manitoba Obstetrics and Gynecology residents, as well as CancerCare Manitoba. And I have the privilege of straddling both of those worlds and working with these great people. I'm Sarah Keane. I'm the medical lead of Cervix Check in CancerCare Manitoba, and I'm going to be your moderator for today. I've got Dr. Rachel Ward and Dr. Courtney Schubert here with me, who are going to be doing some speaking. They're residents in our program at the University of Manitoba. I'm happy that so many people were interested in this webinar, and I hope we get a good turnout. Before we get started, I would like to acknowledge, very importantly, that Manitoba, Cervix Check and the University of Manitoba are in Treaty 1 territory. This is the traditional territory of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. Before we begin with our presentations, I'm going to go through a few administrative items. This webinar is being recorded so that we can make it available for people afterwards. And finally, we're going to try to save the last 15 minutes for questions and answers. We've got a bunch of questions that came through during the registration process. If anything comes up during the presentation, please add them to the Q&A box, which can be found at the bottom of your screen. And if I understand, this is different than the chat box, so try to use the Q&A one specifically. We will go through them and address everything at the end of the presentations. If we run out of time, we will provide written responses to everything and mail it out to all participants. We're going to go on now to our presentation, which has 6 learning objectives. And by the end of this session, we hope that our participants can explain HPV-related disease, identify eligibility and the schedule for HPV vaccination in Manitoba, have informed potential benefit and harm conversations with patients about HPV vaccination, explain coverage and access to HPV vaccination in Manitoba, as well as access resources about vaccination in Manitoba. And then next slide, we have 3 speakers with us today, and these residents have put a lot of work into this webinar, both from a logistics and coordinating as well as material preparation perspective. We have Dr. Marie Jones, Dr. Courtney Schubert, and Dr. Rachel Ward. Our first speaker, Dr. Ward, is going to talk to us about HPV-related diseases, vaccine safety, as well as the potential benefits and harms of HPV vaccination. Dr. Ward is an obstetrics and gynae resident at the University of Manitoba. And Dr. Ward, it's up to you.
All right. Thanks so much, Dr. Keane. Okay, so talking a little bit about HPV here, or the human papillomavirus. We know that about 75% of us will be infected with this virus throughout our lifetime. Most people will clear or fight off this virus and never know that they were infected. However, the reason that we are paying attention to it and concerned is that some of these infections, if persistent, do develop into cancer. Most prominently, we see cervical cancer, but there are any mucous membranes, mouth, throat, nose, oropharyngeal, penile, anal, vulvar, and vaginal cancers associated with HPV-related disease. Next slide, please. We know that there are low-risk types of HPV or strains of HPV that can develop into genital and anal warts. High-risk HPV is associated with cancer. So we'll talk more about which strains of HPV are related with either warts or cancer in a few minutes. Next slide, please. When thinking about HPV-related disease, as I've mentioned, this virus is one of the most common infections in the world. We know that it is spread through skin-to-skin contact, and it can affect anyone. There are some misunderstandings that it is only a female-related infection, but it can affect any sex or gender. In North America, we do know that as mentioned before, about approximately 75% of people have been infected with at least one strain of HPV. And although many clear the infection spontaneously, if persistent, this virus can cause cancers. This diagram does give us sort of a visual representation of of the types of cancer that HPV is related to. So the big yellow portion at the bottom represents cervical cancer, which is 35% of HPV related diseases. Other large chunks that we see are oropharynx. In males, this accounts for 28%, females 7%. And then the other cancers that we've talked about as well, vaginal, vulvar, anal for both female and male, and penile cancer. Next slide, please. So we know over 80% of people throughout their lifetime will experience at least one HPV infection, whether they know it or not. What we do know is that there isn't a way for us to know who gave who an HPV infection. And being vaccinated against HPV can reduce the risk of that infection persisting and developing into a cancer. So I'm going to speak a little bit about HPV vaccine development and safety at this point. So the HPV vaccine, we know that it's a highly immunogenic vaccine that which means it causes a reaction in the body that develops an antibody response. And we know that over 99% of recipients of the vaccine do develop this antibody response. The vaccines that are available in Canada are all recombinant vaccines, meaning that they are made with purified virus-like particles, or VLPs, of the major capsid L1 protein of HPV types. Basically, fancy talk for there's a protein on the outer capsule of the virus that the vaccine mimics, and this is what causes the antibody response. In Canada, there are three types of vaccine, or three vaccines that are authorized for use for HPV. The one that was earliest or the earliest available one was called Cervarix. You can see it is at the bottom of the list here. It provides coverage over strains 16 and 18 of HPV. These strains are commonly associated with cancer. So this vaccine alone provides over protection against over 70% of cervical cancers. The other two vaccines, which may be a little bit more familiar, are Gardasil 4 and Gardasil 9, also commonly called the quadrivalent and nanovalent vaccines. Gardasil 4 provides protection against the same strains of HPV that cause cancer, so 16 and 18, as well as two additional strains, 6 and 11, which are associated with genital warts. It's actually associated with 90% of genital warts. So this vaccine together gives coverage against 70% of cervical cancers and 90% of genital warts. The most recent and most commonly used vaccine today is Gardasil 9, or the nanovalent. And in addition to what the Gardasil 4 provides, it provides coverage over 5 other strains of HPV that are associated with cervical cancers. So you can see them listed there, 31, 33, 45, 52, and 58. So the Gardasil 9 together provides 90% protection against cervical cancer and 90% protection of genital warts. Next slide, please. So thinking about how vaccines are developed and monitored is such an important part of discussing with patients about if they're going to accept a vaccine or why we are recommending it, and how getting their buy-in about getting vaccinated. So some of the information that is important to know is that before a vaccine is approved by Health Canada to be rolled out and ready for use in Canada, it does undergo a long and rigorous testing process. Health Canada does approve vaccines based on scientific review of their quality, safety, and effectiveness. On average, it takes about 10 years of research and development before a vaccine is even considered for approval by Health Canada. And then following that approval, there is a National Advisory Committee on Immunization, which recommends how the vaccine should be used. Once a vaccine is approved, it is monitored on an ongoing basis, not only at a local level, but also provincial and national levels for any adverse events that occur after immunization. An adverse event following immunization, or an AEFI, as some people use the acronym, is any unwanted effect that occurs in a person after they have been given a vaccine. Each case of these adverse events is reviewed carefully to determine if that event was actually caused by the HPV vaccine or something else. And there are systems and groups in place that continuously monitor, review, and recommend after each adverse event associated with immunization. These groups, you can see they're listed here under the AEFI, ongoing monitoring. They include groups such as the Immunization and Monitoring Program Active. It also includes public health nurses, medical officers of health, the Manitoba Center for Disease Control. There's under the umbrella of the Public Health Agency of Canada, there is a Canadian Adverse Events Following Immunization Surveillance System. There's also an Advisory Committee on Causality Assessment, a National Advisory Committee on Immunization, and then the World Health Organization has two subgroups, the International Drug Monitoring Program, as well as the Global Advisory Committee on Vaccine Safety. So these are all resources that you can use if people have concerns about adverse events following their immunization. But overall, we know that severe reactions are very, very low, and most people do not experience a severe reaction and really may experience some swelling or soreness at the immunization site. Next slide, please. So looking at Manitoba, there is some data that shows us that at the end of 2021, just under 60% of males, so 58.1% of males, and nearly 70% of females had received at least 2 HPV vaccine doses by the age of 17 through the school-based program. And Courtney or Dr. Schubert is going to talk some more about what that looks like in Manitoba. Next slide, please. So I want to draw your attention to the Canadian Partnership Against Cancers action plan to eliminate cervical cancer by 2030 in Canada. So these are some big goals, and it takes all of us to reach them. I want to speak specifically about priority 1 here. And that priority is to improve HPV immunization rates with a target by 2025. So that is only a year and a half away. To have 90% of 17-year-olds fully vaccinated with the HPV vaccine. So all 17-year-olds, including males and females. The other priorities within this action plan include implementing HPV primary screening, as well as improving follow-up of abnormal screening results. Both of those have goals set for 2030. Next slide, please. So as I kind of alluded to earlier, the benefits of the vaccine are great, and there are some potential harms. Whenever we talk about anything in medicine, we often get into conversations with our patients about why are we recommending this, what are the benefits, and then what are the harms or risks. When talking to patients and also for our own understanding, potential benefits that come from the vaccination include the protection against high-risk HPV types that are responsible for 90% of cervical cancer. We know that both of the Gardasil vaccines, so the quadrivalent and the nanovalent, protect against 90% of anal and genital warts as well. And we also know that there's protection against other HPV-related cancers and their precursors, including vaginal, vulvar, penile, anal, and oropharyngeal cancers. We know that this vaccine is safe and well tolerated. And something that patients ask is, will this vaccine cause me to have an HPV infection? And we know, because of the way that the vaccine is made, it does not cause HPV infections, and that serious side effects of immunization are rare. The potential harms is that although this vaccine or the Gardasil 9 does cover 90% of high-risk strains that develop into cervical cancer and other types of cancer, it does not protect against all high-risk HPV types. It does not treat existing HPV infections, and we know that some common side effects are soreness, pain, and swelling at the injection site. So at this point, we're going to talk a little bit more about HPV vaccine indications, as well as coverage, and I'm going to hand the mic over to Dr. Courtney Schubert for this.
Thanks, Dr. Ward, for all of that. We are going to move on to our second speaker, who's Dr. Courtney Schubert. She's going to talk about current indications for vaccination, common questions from pharmacists as well as primary care providers, and resources that are accessible. Dr. Schubert is an Obs-Gyn resident at the University of Manitoba as well. Thank you, Dr. Schubert.
Great. Thanks for the introduction. So I'm going to start by talking about the Manitoba immunization program and for which individuals the HPV vaccine is covered for. The Manitoba immunization program covers the HPV vaccine routinely through the school-based vaccination program, as well as for specific high-risk groups of individuals. This is a list on the Manitoba website for vaccine eligibility. It has very dense text that can be used as a quick reference. However, I've broken it up into specific categories so we can go over it more in depth by grouping individuals with similar circumstances. So over the next few slides, I'll walk through these categories of individuals who would qualify for vaccine coverage. Next slide, please. The first category that I broke it up into is healthy individuals, and this is targeted through the school-based immunization program. So all students in grade 6 are offered immunization in school that they can opt in or opt out of. As well as there's the catch-up vaccination for those who missed the grade 6 immunization. This is for females born after 1997 or males born after January 1st of 2002. The next broad category is immunocompromised individuals. So first is immunocompetent HIV individuals. So those who qualify are males aged 9 to 26 and females aged 9 to 45. The next category is anyone with an immune deficiency that's either congenital or acquired. How this is defined is the congenital immune deficiencies include anyone with a B cell deficiency, T cell mixed defects, phagocytotic and neutrophil disorders, as well as complement deficiencies. As well, the acquired immune deficiencies include anybody who is pre-solid organ transplant or post-solid organ transplant, as well as anybody with a hematopoietic stem cell transplant. So anyone who is in either the defined congenital or acquired immune deficiency category, who is a male aged 9 to 26 or female aged 9 to 45 does qualify for vaccine coverage. Next slide. The next categories that I separated individuals into are males and females. So males who are 18 years or younger who have ever been incarcerated qualify for vaccine coverage, as well as males who are 9 to 26 years of age who identify as gay or bisexual. And then females, anyone who's aged 9 to 45 who is a newly diagnosed high-grade cervical histopathology result does also qualify for vaccine coverage. Next slide. The last category I broke it up into is anybody else. So this includes trans males and trans females who are aged 9 to 26. Anyone who's a victim of sexual assault, who is a male who is 9 to 26 years of age, or females who are 9 to 45 years of age. Individuals who are currently or have previously been diagnosed with recurrent respiratory papillomatosis, or those with a hematologic disorder who are currently under the care of a hematologist or oncologist from CancerCare Manitoba. So the hematologic malignancies include leukemia and lymphoma or a clonal blood disorder, and those who have completed or are going to complete chemo or radiation. As well as this also includes anybody who is hyposplenic or asplenic, such as through having sickle cell disease. Next slide. So in addition to all of those individuals that I just discussed, the vaccination is recommended, but may not necessarily be covered for additional individuals. So vaccination is recommended for women and men who are 27 years old and greater, who are at ongoing risk of exposure. So while the peak HPV risk is within 5 to 10 years of their exposure, there is a second peak in women who are 45 years and older. Immunization should also be strongly considered for men who are 27 years and older who are having sex with men because of their increased risk for HPV-related diseases. Vaccination may also be administered to patients that are less than 9 years of age if they are at risk of exposure to HPV, and those would be people who have had have had a history of sexual abuse or a history of a sexually transmitted infection. There's no data on this age group, so it would really be an informed consent discussion with the patient and their caregiver would be the most important for this group of people. Next slide, please. Other HPV vaccination considerations are vaccination prior to exposure to HPV is recommended to maximize the benefit of the vaccine. However, immunization after exposure is still beneficial to prevent other strains of HPV infection. Immunization is beneficial for patients with a history of abnormal PAPs, cervical cancer, or genital warts. An HPV vaccine has no proven therapeutic effect on existing HPV infection and cervical disease. Lastly, booster or re-immunization with the HPV vaccination is not indicated at this time, as clinical trial subjects followed for 10 years showed no signs of waning protection. Next slide, please. So here's an example of the HPV vaccination dose schedule with 3 different available vaccines: the HPV-2, also known as the Cervarix that Dr. Ward talked about, the HPV-4, known as Gardasil 4, or the quadrivalent, and then HPV-9, known as Gardasil 9, or the nanovalent. It should be noted that HPV-2 should only be given to females. So the top row of this chart shows the individuals who are healthy and getting their first dose between ages of 9 and 15. For this age group, and for those that are healthy, they can either get a 2-dose or 3-dose schedule. And the schedule is outlined here. The bottom row of the chart is for those who are 15 years and older, anyone who is immunocompromised, anybody who is immunocompetent, HIV-infected individuals. They should all have a 3-dose vaccination schedule. It can be done with any of the 3 vaccines, and the possible immunization schedule is also outlined here. Next slide, please. So now to discuss how to consent patients for vaccination. First, talking about adverse reactions. The most common adverse reaction is an injection site reaction and muscle pain. In adolescents, their most common reaction is syncope as a response to the injection. Contraindications for the vaccine are a history of anaphylaxis or hypersensitivity after a prior administration of the vaccine, or in people with a proven immediate or anaphylactic hypersensitivity to any of the components of the vaccine or the container. The vaccine is not recommended in pregnancy and breastfeeding with people. Next slide, please. So I'm now going to answer common pharmacist and primary care questions. Our first question is, how can I order vaccine stock from a pharmacy or clinic? So the immunization providers can order vaccines by completing the Manitoba Health's Vaccines and Biologics Order Form. I have the link to the website here. Filling out this form will provide publicly funded vaccines to the providers who are healthcare providers for the sole purpose of administering the vaccine through Manitoba Health's immunization program. Our next question is, how do I report an adverse event following immunization, or an AEFI? So Rachel touched on this a little bit earlier, but I'm going to go into what exactly is an AEFI and how to report it. So a reportable AEFI is an event that is, number one, temporarily associated with a vaccine, and number two, it has no other clear cause at the time of reporting. Of particular interest to Manitoba Health are AEFIs that are either serious or unexpected. However, all AEFIs that meet both criteria 1 and 2 should be reported, unless they are only a mild local reaction and are not overly concerning to the vaccine recipient. So an AEFI is considered unexpected if either of the following criteria are met. So first, it is not listed in the most current Health Canada approved product monograph for the vaccine marketed in Canada. And number two, it is listed in the product monograph, but is different in nature, severity, frequency, specificity, or outcome. So all AEFIs must be reported within 7 days of becoming aware of the AEFI. Furthermore, healthcare providers should report a serious AEFI within 1 business day, which can be reported by telephone, and then you can complete the written report within 72 hours after that serious AEFI. Next slide, please. I have provided the link to where you can find the AEFI reporting form. It's a PDF, and again, this should be submitted within 72 hours of the healthcare provider becoming aware of the serious AEFI, or within 7 days of any other AEFI. Next slide, please. So what consent form should I use? Manitoba Health has provided consent guidelines at the first link shown on this slide. I've already reviewed what you should talk about when you're consenting an individual. However, you can also download the 2 different consent forms provided by Manitoba Health. There's a separate one for child immunization consent form, as well as an adult immunization consent form, and you can save them directly into your clinic or pharmacy health records. So our next question is, can you give me a summary of talking points when I talk to patients about the HPV vaccine? The 5 take-home talking points that we really want to emphasize are, number 1, HPV is a common virus. 80% of people will have at least 1 HPV infection in their lifetime. Number 2, getting vaccinated against HPV can help prevent cancers of the cervix, vagina, vulva, mouth and throat, anus and penis, and most importantly, this is not just for females, but also for males. Number 3, the HPV vaccine works best the sooner it is given to prevent the primary HPV infection. Number 4, for people with a cervix, you should also add that Pap tests are still recommended after getting vaccinated against HPV once you turn 21 years of age. And for 5, if anybody wants more information, you can visit preventhpvcancers.ca. So now I'm going to talk about different resources that you can access. You could feel free to take screenshots of these slides if you want to reference back to them later. The first one is this preventhpvcancers.ca. It provides information about the vaccine. It has vaccine educational videos in both English and French, and it has an option to order resources for your pharmacy or clinic. The next one is Manitoba Health Immunization. This is the link that will provide you to a bunch of the links that I just talked about in our commonly asked questions. So it gives you the vaccine inventory order form, gives you the vaccination schedules, the AEFI process, competency guide for those administering the vaccines, and the resource order form, as well as many other resources. Next slide, please. There's also the CDC information for providers, talking all about the HPV vaccine, as well as other commonly asked questions. And the Society for Obstetricians and Gynecologists, or the SOGC, has an HPV information package, as well as SOGC also has contemporary clinical questions on HPV-related diseases and vaccinations. So that is all for my portion of the talk. I'm going to hand it back to Dr. Keene.
All right, thank you, Dr. Schubert, for that. So lots of information here. I'm just going to talk about a few points that I'd like to highlight. First of all, I just want to emphasize what Dr. Ward had to say about the CPAC recommendations. And to go back in this a little bit, in 2020, November, the World Health Organization declared a global elimination of cervical cancer by 2030. And that's what's really driving these CPAC recommendations. And I just really keep liking to talk about this because I think it's really amazing that in my career, I'm going to go from treating women with metastatic cancer who are dying in their 30s and 40s to being that old doctor who's like, oh, when I was your age, I saw people die from this. And the med students are going to be like, I don't know what you're talking about, Dr. Keene. And I think that is a really achievable goal. And so CPAC has made these 3 pillars of what we need to do. Oh, thank you, Leslie. To achieve that. And they're in line with the WHO recommendations. And I think, I'm really excited to be speaking to this group today because this priority 1 in improving HPV immunization rates is going to be the backbone of this program. And so much of this work relies on primary care and on pharmacy. I unfortunately am in a position that I see people when vaccination is no longer going to be helpful for them. But improving uptake of vaccination in the community is going to be critical. And so to that end, I'd also like, Leslie, if you can, highlight these high-risk criteria again, because I feel like they're not necessarily well known everywhere. There's definitely lots of people who vaccinate widely with this, but not everybody knows about it. And so I want everybody in primary care and in pharmacy to think about, if you have patients in your practice who meet any of these criteria, please just offer vaccination. It is free for these individuals. Gardasil 9, or the non-valent vaccine, is what's being provided by the Manitoba Immunization Program. You can order it from the vaccine warehouse. This is free of cost to the patient and to your clinic, with the exception of syringes and disposables and that sort of stuff, obviously, which you know more about than I do. And then the other thing is to consider the people who meet criteria for vaccination that aren't necessarily free. There's a big cohort of people who were born just after or just before the 1997 who didn't get it in school, didn't have necessarily insurance when they were younger, but still would stand to benefit from vaccination. And these people can still be robustly vaccinated. A lot of people will have insurance coverage, and a lot of insurance policies are now covering HPV vaccination without question. And so offering it to most patients, honestly, I think is going to be important moving forward. So don't forget the patients who are not covered. The ones who don't have insurance and are not covered, it is a little bit difficult. Although I don't know if I'm allowed to say this, but I will say, there's a fair bit of flexibility in interpreting these rules in terms of who qualifies. I mean, any patient who's been sexually assaulted can qualify for vaccination. And so they don't have to go and announce that to every person on their journey to getting a vaccination. And so in primary care, particularly if you were the recipient of that disclosure, please, give it consideration. The other thing that I will say, I think it was Dr. Schubert that highlighted the biphasic incidence of HPV, and there is a cohort of patients, particularly women who are in second relationships after marriage, changes, and they're encountering new HPVs and new partners. And so even though the initial studies on HPV vaccination capped it at 45, assuming that women wouldn't necessarily be having more partners and more HPV exposure, the reality is that they are. And so it may be an off-label use, but it definitely is worth considering for the appropriate patient population, and obviously having a discussion of the off-label use and the benefit that your patient may stand to receive. I think those are the high points. I did just want to mention that although we talked about Gardasil 4, it's actually not available anymore. When they started making Gardasil 9, they said, well, nobody's really going to buy Gardasil 4, so let's just stop it. Cervarix is still available, although it is much harder to come by. And again, my pharmacy colleagues likely know more about that than I do. It's much cheaper than the non-availant vaccine, so that may be an avenue for frank cancer risk reduction in patients where finances are an issue, but they're very motivated or at particularly high risk. So those are all things to think about. And I think we're doing well for time. So I'm going to open things up in the chat, or in the Q&A, not the chat, for questions or comments. You know, I would really love to hear from primary care and pharmacy about your experience with patients seeking this vaccine, or maybe some stumbling blocks that you've come across, because there certainly are barriers to patients in the system. So let me figure out how to open the Q&A. And then, okay, so somebody says, why is the age much younger in terms of cutoff times for men and then women? Please explain. Thank you. That's an excellent question, and it's really driven by the initial studies that that looked at HPV vaccination, and the cutoff was just in the trials was 26 for men and 45 for women. There's no other reason beyond that's what they used in the trials. There's no reason that efficacy would not be valid in older patient populations or in males. So it probably technically is considered off-label because it wasn't in the studies, and the Health Canada approval is largely based on the studies. But again, consent discussion with your patient. Oh, this is a really good question, Sherry. Thank you. If a client has received HPV 4 and is diagnosed with a high-grade lesion, are they eligible for HPV 9? That's a tricky question. It depends likely on how they got their HPV 4 vaccination. If it was funded by the province, it's probably going to be tricky to get a second funded vaccination. But I'd have to go back and look at the timeline of when things became available. So I don't honestly know the answer to that. I would have to look at it. The other thing to consider is the benefit, the absolute benefit in terms of risk reduction. And there's no broad data that says that revaccinating with HPV 9 is going to significantly improve outcomes either. HPV or Gardasil 4 does have robust coverage against 16 and 18. And as long as patients aren't in a kind of high risk situation, I don't think there's a lot of clinical value to revaccinating with Gardasil 9. That said, if they are in a clinically high risk situation, that it's reasonable to consider. Leslie's telling me to recommend that people check the Manitoba immunization manual for questions about having 9 after 4. Okay, Sherry, I hope that answered that. I can get back to everybody with the timeline a little bit better. How are men tested for HPV? That is a challenge as well. The current answer in Manitoba is that they are not tested for HPV. Women can be tested for HPV under certain circumstances through cervical screening. We currently have a triage program. So if they're diagnosed with ASCUS or LSIL, depending on their age on the PAP, they will get reflexively tested for HPV. Currently, this is the only provincially funded access to HPV testing for any patient population in Manitoba, although there are private pay options. I have seen men choose to pay for HPV testing through private labs. I don't honestly know a lot about that because I don't treat a lot of men or any men in my practice. So, but it can be done through private pay options. Okay. Okay, Martha, for a female patient age greater than 45 who does not meet criteria to receive vaccination cost coverage, does a primary care order a Gardasil series through the pharmacy on a prescription? same as Shingrix. I've honestly never prescribed Shingrix, but I do give a lot of Gardasil series on a prescription through the pharmacy. So that's absolutely what I do. I just write it on a prescription because I don't have facilities in my clinic to administer vaccine on site. So I give them a prescription and send them to the pharmacy directly. I have a stamp made up that says patient qualifies for provincially funded vaccine, and I stamp all the people that it's appropriate, and then obviously leave it unstamped for others. So that should be valid method. Okay, what is the risk of developing an HPV related cancer in a heterosexual male? Ooh, that's a really hard question. Again, you're testing my medical knowledge of male patients, which is many, many years ago. And so, in kind of general terms, the risk of an HPV related infection is probably as high as 80 to 85%. And it's only persistence with a high-risk strain that results in cancer. Men do have a number of transformation zones similarly that are at risk, including the anus and the oropharyngeal tract would be namely the highest ones. I mean, looking at female population data, having an HPV 16 has an absolute risk of CIN3 or precancer of about 40%. And if that's left untreated, then the risk of cancer is about 30%. And so just having an HPV infection or even CIN3 is not guaranteed. The bottom line is I don't know the absolute risk to every heterosexual male out there of getting a cancer. Even cervical cancer is about, 2% lifetime risk, I think, in the female population. So it's not super high. I would guess that the HPV related cancers in men is lower. If you look at Leslie, can you find the pie chart thingy that I like? Thanks. There, that guy. And so you can see here that that oropharyngeal cancer in males in general is a substantial burden of HPV related disease. And if you add anal cancers in there, then it's a little bit more. Penile cancer is quite rare, but the other ones are less considered. Deborah, does one develop any natural antibody protection from previous HPV infections? And the answer is quite likely yes. I don't know, if they're as robust as vaccine mediated, which is excellent immunologic response. But yes, likely some natural protection from previous infections. There's likely some degree of cross-reactivity, but there's just something about especially HPV 16 and 18 that just seems to be particularly aggressive. And so having had a low-risk HPV infection likely does not give sufficient cross-reactivity for something like 16 and 18 in terms of cancer risk reduction. Okay. Is it beneficial to vaccinate a woman older than 45 who was previously treated for abnormal cells, not previously vaccinated? Again, I would probably look at risk factors for the individual patient. If this is a 45-year-old who's been in a monogamous relationship since she was 20 and continues in that relationship with absolute certainty, then likely she's not going to benefit from vaccination at this point. If she was previously treated for abnormal cells, she's hopefully cleared that HPV infection. And I'm always careful to say to patients that that vaccination does not clear the current HPV infection. But if she's not going to come across HPVs in the future, then she's less likely to benefit from vaccination. And so, in this patient population, this could be an HPV that she got when she was 20 and now isn't going to be encountering anymore. It's hard to justify, paying $600 out of pocket for a vaccine that she actually may not stand to benefit from. That said, I always say to patients in this situation, if things change, keep HPV vaccination in the back of your mind. I have a patient in my population who, was married for 40 years or something like that. And her partner died when she was, I think, 58. And a couple of years later, she started dating again, normal PAPs all the way through all of that, and had new partners, and unfortunately got HPV 16 and had CIN3. Now she had a leap, but even going through that kind of post loss of her partner was quite traumatic for her. And she said to me, I wish somebody had told me about vaccination when my husband died. Not usually the first thing that people think about when their husband's dying, but if if a patient in your practice is getting ready to re-enter the dating world, then ensuring they have coverage against HPV is a very reasonable thing. Okay, do we have to get the HPV vaccination voluntarily, or will the primary care provider recommend it? I'm not sure what that one means. If you could, it's anonymous, but if you could clarify that for me, that would help. Do you anticipate there will be expansion of cervix HPV screening to include anal HPV screening? That's a good one. There's been talk about an anal PAP program. A lot of the problem is the follow-up and providing anoscopy. There's only, I think, 1 or 2 providers in Manitoba that have training in that area. And it's not, it's often a very small patient population that stands to benefit from it. So again, it's usually a male population that this incorporates, and so it's a little bit outside of my area of expertise, but it's definitely on the radar. I just don't know kind of where things are going with that. Transition to HPV testing may change that as well, but we're not there yet. Okay. Do individuals who test positive for strains 6 and 11, is there a chance they may not present with warts? We don't test people for 6 and 11. And so, you know, that's another, I'm glad this was brought up, but, you know, when people test positive for HPV, the only HPV we're testing for is high risk strains. And so if you test negative, it doesn't mean you don't have HPV. It just means that you don't have one of the 14 that we're testing for. And so most people would never know if they have a low risk HPV, and certainly would never know if they have 6 and 11 outside of presenting with a genital wart. So not a super great answer, but we don't test for it is the problem. Pilot project that ended for self-test PAPs, when are those results going to be available? And do you see that happening again soon? You don't know how many times I get asked this question. So there, I think, are some preliminary results, but I don't know if they're publicly available yet. No, Leslie says not yet. I think we are presenting at a poster at the IGCS, if I remember correctly, though, so stay tuned. Is it going to happen again anytime soon? I don't know if there's going to be another pilot project again soon. You know, my pipe dream would be that when we move to primary HPV testing, which I don't know when, that would be a part of the algorithm that is eligible for patients. But I do not know anything about timeline, unfortunately. Okay, and then there's a couple of other ones in the chat here. Why do some provinces have an opt-in out versus opt-in policy? So that's a really good question that I often talk about when I am giving lectures to residents and that sort of thing. And in terms of the approach to vaccination in the schools, there's 2 different approaches that varies province to province. It's ultimately a legislation and policy-driven approach that is above what I tend to have a say in, although I have started talking to some people about advocacy. And so that is, you know, either opt-in or opt-out, which, you know, opt-in means the permission slip goes home from the school and it says, hey, we're vaccinating your children. If you want them to get the HPV vaccination, please sign this paper. And then the people who are really, you know, value vaccination are going to fill it out no matter what. And the people who do not want vaccination will definitely not do it. But then there's this cohort of people in the middle who are just, you know, really tired parents, or their kid smushes it to the bottom of their backpack and they completely forget about it and it doesn't get done. And that cohort of patients in Manitoba doesn't necessarily get vaccinated. And so if you look at our rates, which I think Courtney or Rachel, I can't remember who showed that, you know, they're not the best in Canada. And with a target in the next year and a half of hitting 90% for these patient populations, this is an important strategy. If you contrast, you know, our approach to Newfoundland, and I only know this because I trained in Newfoundland, not for any other reason, is they have an opt-out. So the permission slip goes home and says, unless you write on this paper, we're going to vaccinate your child. And so all of those, you know, middle cohort of people who forget things all the time, myself included, their children get vaccinated anyway, and their vaccine rate is in the 90s. So it's definitely a very different approach. Do you happen to know, on that note, in comparison to other provinces, where does Manitoba stand in terms of vaccination rates? This 2021 data is a little bit more recent, and I don't think we've seen all of it. And this I don't think is published yet, but Manitoba is close to the bottom in terms of uptake rates, unless something has changed that I don't know about yet. And so that was kind of one of the driving forces for this webinar, is to just increase awareness and try to improve vaccination rates at a community level. There's one more. No, I think that's everything. Any other questions? We have 5 or 10 more minutes if there's other questions. Does this webinar qualify for CME credit? So it does. It's not accredited through the CCFP, so it's not going to be an accredited CME credit, but you can still claim a credit for it. It'll just be the non-accredited type. Lance, why is Manitoba one of the lowest on HPV uptake? It's largely going to be driven by our opt-out policy. And you know, I don't think that we're like miles below everybody else, because a lot of provinces do have an opt-in program. But I suspect that it's got to do with a combination of an opt-in program, as well as our demographics and access to primary care. PC government cuts, I don't know the answer to that. That is well above my pay grade, sorry. But I suspect, you know, access to care is going to be a big part of that as well, unfortunately, which is the reality of practice in Manitoba. All right, I think that's everything, unless anybody else wants to pop a couple more questions into the chat. So on that note, I really want to thank Dr. Courtney Schubert, Dr. Rachel Ward, and Dr. Marie Jones, who didn't speak today, but did a lot of work logistically to bring this webinar to fruition. You guys worked really hard, and I appreciate it. To everybody who came, I mean, there's nothing I love more than talking to people who are, you know, invested stakeholders in reducing cervix cancer burden. And I want to thank you for taking the time out of your very busy days to listen to me talk about one of my favorite things. Heather, there will be a recording available for sure. If anybody has any other questions, you know, Cervix Check and Leslie Baldry is an excellent resource, and she and I work closely together, so she can send anything my way. Okay, a couple more questions in the chat. Do you recommend Pap test on a 21-year-old female virgin? So the easy answer is no, but you have to define virginal status. The guideline very clearly says in patients who have not been sexually active that they do not require cervical screening, but there's more to sex than just a penis and a vagina, and somebody may identify as a virgin because they've not had a penis in their vagina, but they may have some sexual activity with another partner. And, you know, I just want to stress that it doesn't matter the gender identity or sexual orientation of the person or the partner. If a patient has a cervix and has any sexual activity with any other person, including oral sex or digital sex, or I generally say kind of tongue-in-cheek, anybody touches you below the belly button, you should probably consider starting cervical screening in that patient population. And so if somebody truly has never been sexually active, then no, Pap testing or cervical screening is not indicated. But if there is other, then yes, for sure. Uptake of vaccines in northern, rural, and remote indigenous. I don't think we have that data yet. I suspect it's going to be in some of that as it comes out. We do have data that says that cervical screening is likely lower in northern and remote communities. And I suspect that vaccination follows suit, but we don't know that for sure. I think it's probably going to come out of this data as it evolves, though. Okay, partner of an older male diagnosed with HPV-related tonsillar cancer, should they get the vaccine now in their 60s? Again, probably if, you know, that male with the HPV-related tonsillar cancer has had his HPV for a while and has already likely shared it with his partner. And so vaccination for the partner, or do you mean vaccination for the male? Well, I'll answer both of those questions. Again, the vaccine doesn't treat existing HPV infection. And so probably both the male patient and the partner have swapped their HPVs back and forth quite a while. And so if they're not seeking new partners outside that relationship, then less value in vaccination. But it's not wrong either, depending on the circumstances. You know, if it's a new partner of this older male, then it likely could be a reasonable thing to consider. But it's a little less clear. Oh, good question, Sarah Deep. If a patient had one dose and came back after 6 months or more, should you restart the series? And the answer is no, you do not have to restart the series, just continue vaccinating. And under 15, children only need 2 instead of 3 for the series. I think Courtney talked about that, but just to clarify. So many good questions. Thank you. Thank you, people. Okay. And on that note, like I said, if any other questions come across, please email Leslie. We are always happy to reach out. She can answer a lot of things because she knows this area well, but if she can't, she sends it to me. Oh, there's her email in the chat. It's just screening@cancercare.mb.ca for those of you who can't see it. Our website, preventhpvcancers.ca, and CancerCare's website has a ton of resources on there. So there's lots of things out there, but we're always here, whether it's questions about cervical screening indications, vaccination indications, how to access it for patients. I'm always happy to answer questions. It's my favorite part of my job. So thank you. Oh, Leslie says, I'm supposed to tell you about certificates and evaluation. Things will come in the mail or in the email, sorry. And there'll be participation certificates and a forwarded evaluation. Please give us feedback if we can do anything differently, better, more frequently, less frequently, then we're happy to do that. All right.